On behalf of the Department of Human Genetics and the University of Michigan Genetic Counseling Program, we're really excited to welcome you to the 16th Annual Diane Baker Alumni Lecture. Today, we will be honoring Kate Partinsky-Emery, a 2015 graduate of our genetic counseling program. It's been a real thrill to welcome Kate back to Ann Arbor. I think it's her first time back since she graduated, and we're looking forward to a really great seminar this morning. By way of brief introduction to today's event, let me talk briefly about the award's namesake, Diane Baker. As many of you know, Diane's career at Michigan spanned over 25 years, and during this time, she founded the Genetic Counseling Graduate Program and served as the first program director. In addition to her role as an educator within the Genetic Counseling Program, Diane also provided genetic counseling in pediatric genetics. She administered the state's newborn screening program. She coordinated outreach clinics in northern Michigan, and she also provided outreach to local teachers and students. Diane's impact extended beyond the University of Michigan and the state of Michigan, as she served in leadership positions in all of the nation's genetic societies. She also co-edited the first textbook in genetic counseling and was involved in the 2008 passage of the Genetic Information Non-Discrimination Act. Diane often joins us for this event, but she's traveling abroad with her sister right now, so she's unable to join us. We'll excuse the absence for this year, and we look forward to seeing Diane back with us next year. When we initiated this award 16 years ago, our goal was to identify members of the alumni community whose activities honor Diane's legacy. This year, again, we are thrilled to honor Kate, who actually exudes a lot of the same warmth, caring, and welcoming presence as Diane. Kate earned her BA in biology from the University of San Diego in 2013. And then here at University of Michigan, she earned her MS in genetic counseling and also developed very strong friendships with her classmates who dubbed themselves the Fab Five. And it's kind of cool to see Kyle joining us today from Indiana and Michelle, two of her classmates with us. So when Kate wasn't enjoying high tea, snowy afternoons in Ann Arbor or Central Park, or hobnobbing with Francis Collins, she was hard at work across our curriculum in the classroom, clinic, and research. Kate's thesis examined paternal adaptation to a child's diagnosis of Fragile X syndrome, and she was awarded the 2014 Jane Engelberg Memorial Fellowship from the National Society of Genetic Counselors. After graduation, Kate began her genetic counseling career in pediatric genetics and newborn screening at Children's Hospital of Orange County. She then transitioned to a career in cancer genetics, first at USC Norris Cancer Center, actually with one of my colleagues or classmates, and then at Providence Health System. In 2021, after many years as a clinical genetic counselor, Kate moved into a research role at Providence, coordinating the Genomic Medicine for Everyone study, a pilot project involving research-based whole genome sequencing with clinical return of results. Kate now manages a portfolio of population-scale genetics programs that serve the entire 7-state Providence Health System. These programs include inherited cancer and cardiovascular screening programs, pharmacogenomics, population sequencing, and precision oncology initiatives. So please please join me in welcoming Kate back and congratulating her on this committee, on this award. I didn't have my coffee this morning. And I would like to thank the committee as well for their service choosing this. Congratulations. So again, today's going to share some of her work in her presentation, and we're looking forward to it.
All right.
Congratulations.
Thank you, Monica. All right, well, I loved seeing some of those pictures. I was joking with some of my colleagues that I don't feel old enough to be receiving this award, but I'm very, very excited and honored to have received it and to be sharing our work at Providence Health System with you today. So again, I'm Kate Emery. I'm the Senior Clinical Program Manager for Genomics at Providence Health, which is based on the West Coast. And today I'm going to be talking about our work in advancing genomic medicine in community healthcare to increase equity, access, and engagement through population genetic screening. A brief overview of what we'll cover today. First and foremost, some of the gaps in genetic risk identification and how population scale screening strategies can be used in community healthcare to try to address some of those gaps. Increasing equity, patient engagement, and scalability through two of our program initiatives, the Prevention for Me program and the Genome for Me program experiences, and some of the lessons learned and future directions from those programs. I wanted to first start, though, by describing the problem and sort of the tip of the iceberg here. So more than 1 in 100 people, more than 1% of individuals in the US has a pathogenic variant linked to hereditary disease. But up to 90% of these individuals remain undiagnosed. So there's a huge gap there. We know that many of the individuals who carry this predisposition have not been found yet. And so that represents a potential loss, losing out on prevention, early detection, and cascade testing opportunities. Some of the barriers to hereditary risk identification include lack of knowledge from primary care physicians, who are often the entry point for identifying these individuals, unclear navigation within complex care networks within the US healthcare system, racial inequity in referral and testing rates, cost and financial barriers. Even when patients may be insured and have coverage for genetic testing, their out-of-pocket costs may be high. And then finally, genetics workforce capacity. There have been great strides in increasing the genetics workforce, both in terms of medical geneticists and genetic counselors, but the fact remains that there's still only about 1 genetic counselor to every 100,000 patients in the US, and 1 medical geneticist to every 250,000 patients. And many of them are often geographically concentrated in urban centers. So one approach to try to address that is population screening. And here, population screening refers to genetic testing for entire groups of people, generally asymptomatic or well populations, to identify those individuals who may be at higher risk for specific genetic conditions. And the goals of population screening are to detect carriers before preventable disease onset. So conditions like cancer or cardiovascular disease that have opportunities for early intervention before the symptoms start. Another goal is to reduce or eliminate the need for family history collection and clinician referral bias by building systems that more automatically identify these individuals. And then finally, to identify risk more equitably across diverse populations. Again, kind of building these systems that don't require the clinician to identify these people. Providence is definitely not the first health system that has built these kinds of programs. A few of them are listed on the slide here. So Geisinger had the MyCode project. Ambry Genetics, an industry company, has a tool called the CARE program. North Shore University Health System, of course, the Healthy Nevada project, near and dear to my heart since I live in Nevada now. And then finally, the All of Us research program through the NIH. You'll notice, though, that several of the programs on the previous slide, they may be large-scale research studies that are not necessarily tied back to clinical care. And Ambry, of course, is a commercial for-profit entity. So in order for these programs to really be the most efficacious, they have to be tied back to clinical action. So that's what we were really interested in at Providence in building out our population screening programs, using community healthcare as sort of the gateway for these services because it poses a huge opportunity for a large patient population. And so again, embedding genetics into routine, trusted care pathways could potentially ensure better equity and more follow-through for patients in their downstream care. So I'm going to talk a little bit about how population screening in community healthcare specifically can represent a big opportunity. This is to show you the reach of community healthcare in the US. You may know this already, but 60% of Americans receive care in community health systems. Community health systems focus on providing healthcare, as the name implies, to the community. So they provide healthcare, health education to the local community through preventive visits like mammograms and colonoscopies, chronic disease management like heart failure, diabetes, chronic kidney disease, cancer survivorship. And some of the benefits of community healthcare are geographic accessibility. Patients don't have to travel as far to receive that care. There's trust in local providers who may have a more longitudinal relationship with that patient. And because of that, there's also care continuity. So if we can meet patients where they already are located, we can embed genetic screening into that existing care. We can potentially reach more diverse populations, both in terms of racial, ethnic diversity, language, geographic, socioeconomic, and we can reduce disparities in access like dependence on specialty referral or patient travel. So I've seen this in my own career. Another blast from the past with this was our first day of genetic counseling training up at the top there. I started out my career as a genetic counselor who provided direct patient care. My first job, as Monica highlighted, was at Children's Hospital of Orange County, and I had the opportunity to also work at a newborn screening referral center at CHOC. And so there was that public health connection there that was always very appealing to me because I saw the power of being able to screen large populations, identify conditions that had early intervention opportunities, and also the logistics that went into that. When I worked at USC, we also had several precision oncology programs that were aimed at trying to offer sequencing to patients kind of at the front door, both in terms of germline testing and then also somatic sequencing. And when I moved to Providence, I expanded on that. So I was still providing direct patient care in a cancer genetics setting, but the clinic that I worked in had these programs in mammography and endoscopy to try to reach more patients at the point of care and offer them genetic screening, genetic referral opportunities so that we weren't missing patients in the population. And Providence is a great model system for this because we are a very large not-for-profit health system in the US. So we're in a unique position to try to engage these different patient populations. We're a 7-state community health system that spans from Alaska all the way down to Southern California, and then out east to Montana, New Mexico, Texas. And there's diverse patient populations that we serve as part of that health system, including racial ethnic diversity, socioeconomic diversity. 70% of our patients are on Medicare, Medicaid. We also, because of some of the states in which we operate, we have a lot of rural health aspects to what we do, as well as particularly in some of our urban centers, like in Southern California and Washington and Oregon, many patients who are non-English speaking. So again, there are both equity considerations for the work that we do, and then also scalability considerations that other health systems may not have. So the goals of our population screening programs are to identify more at-risk patients earlier, enable access to precision therapies and risk-reducing care in patients' own backyard, expand equity and justice in access to genomic medicine, and inform health system planning and resource allocation. So for example, for identifying a lot of patients who need downstream care, we want to make sure that there's service capacity to be able to do that. So we've done this in a number of ways. Providence Genomics, which is the department that I work for, is under the Institute for Clinical Innovation at Providence. And we have a number of different infrastructure initiatives, clinical programs, and research programs that fill out this ecosystem of care within our community health system, specifically for genomic medicine and personalized medicine. So we've built things like patient education and consent platforms. We have integrated with the Epic Genomics module so that data from our genomics programs flows more seamlessly into our electronic health record. There's clinical decision support for clinicians that feeds from that. In our clinical programs, we have a focus for each one. I'm going to talk about two of them today, which is the Prevention for Me and the Genome for Me programs. And then those are sort of the front door for other research initiatives that we have, including a large-scale research registry. So I say all of this to paint a picture for you that for many of our programs and for much of what I'm talking about today, we build these programs, we test if they work, and then we feed that back iteratively to make them better for all patients across Providence. So two learning examples today. One is the Prevention for Me program. And this is really to improve the accuracy and reach within the existing paradigm within genetics of using personal and family history to identify patients. This is a clinical program that right now is primarily based in our mammography centers, but we intend to expand out over time. And it involves, again, family history-based detection and cancer genetic risk assessment at scale that is leveraging digital tools to do that. And then later today, I'll talk about the Genome for Me program, which moves further upstream in that process to true unselected population-based screening. This is a research program that involves a whole genome sequencing biobank with population screening in the sense that we returned results for a select set of genes and enriched recruitment for underserved populations. So to start with the Prevention for Me program, as I mentioned, this is a program that is focused on developing a lab-agnostic, comprehensive risk screening solution that includes tools and processes to enable cancer risk screening at scale, sort of an extender of traditional genetic counseling services. Our goals are to expand the opportunities for patient care, reduce barriers to cancer genetic risk assessment, and improve access to personalized care, develop screening tools and methods that integrate into the workflow of our caregivers, and ultimately to improve patient outcomes by detecting those with genetic risk earlier. So this program right now includes an automated calculation of the Tarek-Huzik lifetime breast cancer risk score, which for individuals who have a 20% or higher lifetime risk of breast cancer, it's a breast MRI indication for enhanced screening. We also assess whether patients meet NCCN criteria for hereditary cancer testing eligibility. And for those who do meet that criteria as identified by the program, we offer workflows for same-day genetic testing and education about preventive options. And the reason that we do this in mammography is that we want to try to introduce these programs at moments where patients are already in the mindset of preventive care. So routine cancer screenings, primary care visits, high-risk clinics, et cetera. This is a snapshot of the workflow that we use. So our system sends out invitations to patients a week prior to the appointments at which we offer this program. There's an email and text message outreach that goes out to them. Patients respond to the questionnaire that's embedded within that, receive education about what their results and assessment summary means. For those who are eligible for genetic testing, they have the opportunity to consent within that same platform. And when they turn up for their appointment, in this case, a mammogram, much of that workflow is already done. So at that time, the genetics assistant or genetic counselor checks in with the patient about their understanding, make sure that they're ready to go, they've signed the consent, and then they can just collect their sample that same day. This is what it looks like. There's also MyChart login so that the patient has that additional layer of trust that this is a legitimate assessment and something that we want them to fill out. They have a dashboard that they have access to so that they can see their assessment summary, they can see their genetic testing results all in one place. We've also embedded some different educational resources that were developed by our genetic counselors within the Providence system, including an educational video that is the first step towards the e-consent, so that the patients receive standard pre-test counseling elements through that video. Genetic counselors also have access to a dashboard so that they can see kind of in aggregate how to manage these patients based on their responses to that assessment. In terms of the numbers, this is the data from our first year in operation under Prevention for Me. There have also been programs within the Providence system that were running under the Ambry Care program in Southern California. But this is the first 6 sites over the last year. So there were 62,000 patient encounters across these sites, which had staggered rollouts. So this is not all 6 sites from June of 2024, but over the past year. 41% of those completed their assessment, so about 25,000. There's another drop-off point there as far as who actually qualified for NCCN-based testing. 22% of those individuals got tested, so a little under 2,000, and then we had about a 6% positive rate for individuals who had a positive variant. About 13% of the patient population who completes the assessment also has a Tyrer-Cuzick score that is over 20%. We're doing an analysis right now of how many of those individuals actually completed an MRI within the system. So you can see on the right there, there are certain steps where we try to automate a lot of this process through the workflow that I just showed you. So integration, education platforms, user-friendly engagement tools, so that by the time that the patient gets to a genetics assistant or a genetic counselor, a lot of that workflow is already completed. And then genetic counselors are able to consult with the patients who really need us. And there still is that genetic counselor oversight over the entire process. These are the demographics of Prevention for Me patients. You can see on the left there the race ethnicity breakdown. This likely represents the mammography population. It's predominantly a white patient population. I did not show you the female versus male breakdown because mammography, it is 99% female. And again, with the age distribution here, most of our patients are over the age of 40. Again, just based on the age at which we would expect somebody to be receiving a mammogram. As you saw from that funnel, one of the problems that we experience in programs like this is that there are steps of patient drop-off. So in order for someone to actually go through and receive the testing, they have to get through the assessment. They have to, open the assessment in the first place. They have to complete the genetic test itself when they are found as eligible for that. And once they're identified as having elevated risk, they also have to complete the screening and preventive care that's recommended to them. And so you can imagine there is that degree of drop-off at every step. So we want to try to minimize or reduce that. And so one of our goals in a study that we did was to understand those patient experiences and what may motivate patients to complete the full genetic screening and testing process. So what were the facilitators and what were the barriers? I'm showing this because there are slightly different numbers that you'll see in some of the subsequent slides because we focused in specifically on a Southern California population. And those individuals at that time were going through the CARE program in Southern California. So our aims with this patient experiences study were to capture patients' perspectives on genetic risk assessment, testing, and connection to follow-up care in the Ambry Care program in Southern California at Providence to inform the implementation of our Prevention for Me program across the Providence health system. I wanted to surface those barriers and facilitators to successfully engaging in screening, testing, and follow-up care to help support the uptake of precision medicine among patients. So we worked with the Center for Outcomes Research and Education at Providence to do this work. And CORE conducted semi-structured qualitative interviews with patients in one of the 6 participating mammography clinics in Southern California. There were different groups that were interviewed, one who did not complete screening at all, so did not complete the assessment, one who met the criteria for testing but ultimately did not proceed through with the genetic test itself. And then group 3, the group who tested and more specifically tested positive for a pathogenic variant. Participants were asked about their views on genetic testing, what could or did motivate them to receive a genetic test, including any history of prior testing through other programs or traditional genetic counseling models, and then any barriers or facilitators they encountered during the process. To show you kind of the steps in the drop-off process, this is where group 1 fell. It's the individuals who did not complete that assessment from that very top of the funnel. Group 2 was the people who could have gotten tested but may not have. And then finally, again, group 3, those who did and had a pathogenic variant. The demographics of the participants reflected again, our mammography population. So the average age of the participants in this patient experiences interview study was 59. 81% of them identified as white, 89% spoke English as their preferred language, and 62% had commercial insurance. A few of the highlights, which we'll dive into each of these. Number 1, the communication of benefits to patients is really important for helping encourage them to go through this process. Patients really want to know, what are the next steps? How do I do this? What's in it for me? What's the benefits if I learn this information for me and my family? And they need that support to take action at every step. Repetition and timing also matters a lot. So people hear different things at different times depending on what's going on in their life at that moment. And so it helps to have those recommendations multiple ways and at multiple times. Information and knowledge. Patients need additional clarity around the screener, the assessment, and the test, including why they should take them and what exactly they entail. And then trust and guidance. Patients really benefit from clear communication and hearing those recommendations from trusted providers at every step of the way. So to give you a snapshot of each of these, for communication of benefits, the whats and whys of the recommendation for genetic testing or genetic screening are not always immediately clear to patients. And for follow-up care, a lot of the responsibility for those next steps really does fall on them. I know we talk a lot about you have to be your own advocate, but that seemed to be very, very reflected in the interviews from these patients. One quote there is, so I went in for my first mammogram, and I think you do a risk factor analysis that gives you a number of your lifetime risk of breast cancer. And my number was really high. And so I remember I did the mammogram, and then they said, do you want to do genetic testing? And I said, no, I don't need to know. And it was just the ultrasound tech. He was offering it, and I really didn't have any understanding or no idea the extent that it could provide information. Repetition and timing, as I said, multiple recommendations and exposure to genetic testing in lots of different settings can be helpful for these population screening settings, especially for patients to be able to move through that process. One quote here is, I found that a lot of the stuff I just didn't want to know. I was very focused on getting rid of the cancer and jumping through the hoops that the doctor wanted me to do. So all the other stuff, like genetic testing, it's It's like, okay, you just do your thing and I'm going to try not to die during chemo. Another quote was, and then this year, I can't remember what was going on. I think my husband had a surgery and my son's school team was competing, and I don't have time to do this. I figured I'll do it next year. So sometimes there's just factors outside of the program's control that are going on in that patient's personal life that just means that they're not ready to do that screening at that moment. Knowledge of genetic testing is another big one. Patients might have some exposure to genetic testing from prior experience, but they don't always know exactly what the test is, what it entails, or what you can learn. And this is sort of on a basic level. I was actually kind of surprised to see this quote on the left. I'm not even sure what entails genetic testing. Is it a blood test? Is it, a biopsy kind of thing? So sometimes there's even misconceptions about how easy that testing can actually be. Another misconception on the right was, I thought it was saying that if you have cancer, if I'm already sick, would I be interested in it? And that was probably in my mind too. Like, no, I'm fine, I don't need this. So I just didn't understand it. And finally, trust and guidance. So in general, if something was important, then patients preferred to hear about it from an actual person, not through my chart, not through mail. Something that light touch was interpreted as the test not being urgent or overly important. So this participant said, I'm not sure that coming from a mammogram tech, it would carry a lot of weight. If my oncologist suggested it to me, I would probably do it. And as far as who patients consider to be trusted providers, none of the participants identified the mammography center staff as the trusted provider, which to us was important to recognize because this is where a lot of our programs are operating. Typically, patients reported a positive relationship with their oncologist, their primary care provider, or their genetic counselor. There were some limitations in the data for this particular study. Number one being engagement in care. So the participants came from a sample of people who had received mammograms recently. They were already engaged in care. So we were not able to interview individuals who don't engage in care at all or non-mammography settings at that time, since we have not had not yet launched in non-mammography settings. Second, the people who opted into an interview were self-selected. So they were generally proactive around their care already as well and had an interest in genetic testing. And then finally, categorization. The 3 interview groups did not complete the screener, did not get the genetic test, tested positive. We're not always exact because of the dynamic nature of the patient status in the portal in which we drew participants from. Nonetheless, there were some important takeaways from this, both at the individual level, the provider level, and the system level. Patients' perceived risk, their knowledge of genetic testing, their ability to navigate health systems, and their general bandwidth really shape the way that they engage with programs like Prevention for Me. At the provider level, patient relationships with different preferred providers, including who was the person who gave the testing recommendation, and the sense of importance that they gave to that, can influence whether an individual proceeds through the process or not, and can change how patients approach that testing. And then at a system level, and a lot of what I spend my time in on my role is trying to coordinate between providers and within the health system, including minimizing redundant forms. We hear all the time anecdotally from patients, and in this study more formally, how patients just don't want to fill out the same things over and over and over again in the same format. So trying to better automate that, pull in information from the electronic health record where we can to try to minimize some of that redundancy and make it more aligned with what they've already filled out before. And then, of course, making sure that there's alignment between different providers about the importance of these kinds of programs and the benefits that they can give patients. So some ongoing prevention for me work that we are engaged in right now is the economics of these programs and sort of the operational projects that we have going to understand how well these programs work and the value that they bring to the health system. Addressing assessment completion rates, since, as you saw in that funnel, there's a pretty significant drop-off with the people who even open the questionnaire to fill it out in the first place. So we want to address that in this coming year. Scaling to non-mammography settings within Providence. We have a grant submitted right now to do some work around an environmental scan to look at where some of the fertile ground may be outside of mammography, including primary care. And then continuing to address some of the barriers and facilitators to that downstream care after somebody is identified as a mutation carrier. And then finally, trying to weave this all back together into the electronic health record, EPIC, so that once someone is identified, it's much easier for other providers outside of genetics to see that and recognize it and know what's next for the patient in terms of their care plan. So prevention for me, again, is really an improvement on the existing history-based paradigm. This is our attempt to use our genetic counseling workforce at the top of their scope, make sure that we have extension of the family history-based paradigm throughout our health system. But now I'm going to switch gears and talk about Genome for Me. Both of these programs address the same underlying problem, which is that too many patients with hereditary risk are going unidentified. And both focus on improving equity, access, patient experience. But Genome for Me, as I said, goes upstream of that to unselected populations and offering testing to all patients regardless of family history. So what I'll show you is some data on feasibility of that model, engagement, and then the diversity of the reach that we achieved with that program. So first, to further define unselected population screening. So ACMG and CDC both define that population screening is justified for certain conditions that are unselected for family history because they meet these different criteria. So there's known effective interventions that exist to prevent or mitigate that disease. They are high penetrance, so the genetic variant has a high probability of leading to severe disease. Severity of that disease is enough to warrant medical intervention, and the condition may be missed by traditional history-based screening. And many of these population screening programs are really enabled by improved technology, automation, reduced cost of sequencing, et cetera. Some examples of the conditions that we may be thinking about are hereditary breast and ovarian cancer syndrome caused by pathogenic variants in the BRCA1 and BRCA2 genes, Lynch syndrome, and then many of the conditions that are on newborn screening. So for the Genome for Me study, we focused on the adult population and did population scale whole genome sequencing as a pilot to build out the infrastructure for this kind of program in our Providence health system. So this is currently closed for recruitment. It's a set cohort. We recruited 2021 through 2023 and are still in the process of ongoing longitudinal follow-up through surveys with these participants for 5 years post-enrollment. So we'll be continuing this through 2028. The goal of that was to create a scalable foundation for adoption of genomic medicine in our 7-state community health system. We oversampled for underrepresented groups and had an equity-focused outreach to try to reach populations who may not historically have had as much access to genetic screening. We also wanted to validate the use of whole genome sequencing for return of actionable results at this scale internally through our Providence Molecular Genomics Laboratory. and then enable continued genomic research because the whole genome sequencing as part of this research program was to create a biorepository that was matched with clinical data. So to give you a sense of the study model and how this worked, we would select and invite the patient. There were 2 different cohorts for that. One was through participating clinics where the study team would identify patients who had an upcoming appointment and would send an invitation to participate in this study to that clinic cohort. There was also an outreach cohort, which is more of a cold outreach to larger samples of patients, which I'll talk about that in a moment. Patients consented to the study electronically, remotely from their home, filled out a health history questionnaire, and collected their samples remotely as well. This was a saliva-based collection method. Samples were sent to our in-house Providence Molecular Genomics Laboratory where they were sequenced. The de-identified whole genome sequencing data was entered into our research data set. And then a clinical report with return of results was returned back to the participant. And an important note here is that this was not an optional results return. All participants in this particular study did receive a clinical report if they participated. So if they did not want to receive results from the study, then their option was to not participate at all. Also importantly, we did not return variants of uncertain significance as part of this study. So for individuals who had a negative report, that was passively released to both the patient and their provider that they had designated as their Providence provider at the time that they enrolled. And then for positive results, the study coordinator reached out to the patient and their provider to notify them that a pathogenic variant had been identified and to help coordinate the patient to genetic counseling services, which were provided by Genome Medical at the time. We also returned pharmacogenomic results as part of this study, so there was also the availability of a pharmacist consultation. For the sequencing and analysis and the return of results panel, this was a CLIA and CAP validated whole genome sequencing based test. And then results on the panel that you see to the right here, which is very tiny, I know, were returned to participants. So these included 78 inherited disease genes, which were based on the ACMG secondary findings 2.0 panel, and or National Comprehensive Cancer Network guidelines. And then we also returned 5 PGX genotypes that had metabolizer status and gene drug prescribing guidelines from CPIC, FDA, or the Dutch Pharmacogenetics Working Group. So those are listed there. And these were based on the 7 top prescribed medications in the U.S. and the general population, and PGX associated with those. So this is a summary of enrollment here. Uptake was indeed higher in the cohort who were invited through clinics. So we contacted in total 30,000 patients across the Providence population, and we had about a 7 to 8% consent rate, so 7 to 8% uptake, so about 2,000 participants who consented. 75% of those in the outreached cohort returned a sample, and 80% in the clinic invitation. So kind of similar sample return rates, but the consent rate was a little bit higher in the clinic invited group, 15% compared to that 7 to 8%. So it may be that having a provider kind of, again, give you that recommendation or encourage you to participate in this type of research helps to encourage that participation. These are the demographics of the enrolled cohort. So we had a population that, again, was predominantly white, but less so than the mammography population that you saw in the Prevention for Me program, so 53%. We also had a distribution across age ranges from 18 all the way up to, I believe our oldest participant was in their late 80s. And about 2/3 of the cohort were female as opposed to male as for sex at birth. This is the spectrum of inherited disease panel findings. About a little less than 8% of participants had an inherited disease finding. Many of these were in genes associated with hereditary cancer predisposition syndromes. We also had those associated with cardiovascular syndromes, and then others. And then for PGX findings, all of the participants received a PGX report with at least one recommendation for future care management. But as far as the individuals who had an actionable finding at that specific moment that they received results, it was about 14 to 15% had an actionable finding based on the medications that they reported currently taking at enrollment. Most of those were proton pump inhibitors. Others included antidepressants like SSRIs and anticoagulants or antiplatelet agents. In previous programs, such as Geisinger My Code, the All of Us initiative, we looked at how to best engage some of these participants based on the previous programs. And a lot of those programs emphasize the importance of relationship building to achieve large-scale enrollment in these whole genome sequencing or genetic screening programs. But what we found is that individual outreach is not always feasible at scale. Doing things like outpatient visits, blended community engagement, paper-based outreach, or mass media campaigns. There's also a lack of consensus in the effectiveness in different types of outreach methods to encourage participation in genomic research, particularly the most effective methods for underrepresented populations. So we worked with CORE again to do a study to look at what are some of the effective methods that work for different patient populations at Providence to recruit them into Genome for Me. So we used stratified random sampling to recruit a diverse patient population to participate, and then looked at different response rates overall and then across demographics to understand the effectiveness of those different strategies. The demographics of interest were race, ethnicity, spoken language, particularly individuals who are non-English speaking, socioeconomic status, and as a proxy for that, we used insurance type. And then to do this, we sampled 6 different strata in order. So one was the general population, all eligible patients over the age of 18 who had a visit to a Providence provider within the past year. Individuals identifying as Hispanic or Latino, Latina, Latinx, individuals identifying as Black, individuals identifying as Asian, individuals with Medicaid as the primary payer, and then individuals residing in a zip code that's designated as rural. So there were 2 different approaches here, one that was digital only and one that involved a brochure and digital outreach. So for the brochure plus digital group, the brochure went out first. If the participant enrolled from that outreach method, they were removed from the outreach pool. But if they did not, they received an email and an SMS text outreach, and the same process there was repeated. They got an additional outreach by email and text if they did not enroll. For the digital only approach, as the name implies, it was digital only. So they received email and SMS text for all steps in that outreach process. And this is what we found for the outreach effectiveness. Overall, there were no major differences by the outreach method. So Overall in the study, there was about a 7.5% uptake of enrolling in the study. In the digital-only outreach group, it was 7.3%, and in the digital plus physical hard-mailed brochure, it was 7.8%. So no significant differences there. An important note, though, is that Asian patients and patients residing in rural areas both enrolled at higher rates when they were receiving the mail-based brochure as opposed to just digital only. We don't have a great explanation for that, but that is an area that would be very interesting for future work. When we look by subgroup, there was higher study uptake in patients who had Medicaid as their primary insurance, 8.7%, and then individuals who were in rural zip codes, so 10.6%. So that was encouraging in the sense that we are able to potentially reach patients who are in rural centers who are not able to travel to the genetics clinics that we have in our health system to participate in this kind of screening and research. Unfortunately, though, we saw that there was a lower study uptake in individuals who were part of underrepresented racial and ethnic groups. For individuals of Hispanic descent, it was 5.4%. Black or African American was 5.6%. And then for individuals who had Spanish as their primary language, it was 2.8%. So we have a lot of work still to do to make this better and to make it more equitable. We do offer Genome for Me in both English and Spanish, but the very low uptake in the population who has Spanish as a primary language was something that was concerning to us, and we want to make sure that we can address that in future work that we do for population sequencing. So again, some of the takeaways here. One is that digital-only outreach may be feasible. You know, if you're given the choice between having to send out a brochure or warmer touch methods of outreach compared to just doing email and text message, it may be feasible to just do email and text message for that, with the caveat that you do need tailored strategies for equity, and if there are specific patient groups that you may want to reach, some of these strategies might work better for certain groups than others. But overall, for us, especially because Providence is such a broad geographic footprint, being able to do digital-only outreach is something that we have taken with us to future iterations of all of our programs, because it also helps as a cost measure as well to not have to send brochures. And as I mentioned, future work, we hope to more deeply explore some of those reasons for the lower uptake in specific populations that we observed as part of this study. So some of the ongoing Genome for Me work at the program level, we have a manuscript under review right now for some of the health behaviors that Genome for Me participants have undertaken in the years since enrollment and receipt of results, including how they share their results with their providers. We also continue to do survey follow-up for longitudinal health behaviors, health screening. We're working on a manuscript for that right now. We also have an interest in looking specifically at the PGX aspects of this, and because these results are in our electronic health record and trigger things like clinical decision support alerts to our providers, we're working on preparing that manuscript right now to look at some of the provider actions that they took following an alert for a PGX drug-gene interaction. And many of our Genome for Me participants have also participated in different focus groups for our, what we're kind of referring to as Genome for Me 2.0 as part of our Discover Research Registry program. So lessons learned from these programs and others for scaling genomic medicine within our community healthcare system. Number one, if we embed genetic screening in routine healthcare, whether it's family history based or population screening, but particularly population screening, It can significantly increase the reach of genetics and also equity. You saw the difference between the mammography demographics and the Genome for Me demographics. We can have a broader reach and make sure that we're reaching not just white, middle-class, female populations if we do these types of programs. Technology and automation can also help enable that scale, but the flip side of that is that connection and patient trust are really what enable participation. So we still have to keep the human in human genetics and make sure that those trusted relationships are built, and that's how we can encourage patients to enter these programs in the first place. Equity also isn't automatic. We have to build it in to really make sure that we're reaching the patient populations that need us the most and may not have had historical access to these types of programs. And finally, genetic screening is a continuum. I firmly believe that if we were to debate the merits of family history-based screening versus unselected population screening, I think it's a both and, not an either or. Both of these have different pros and cons. There's different approaches, different outreach methods that may work better in some populations than others. So having both at the same time can be really powerful. So I mentioned some of the what's next here. We're trying to expand this. We want to reach basically every Providence population with some form of genetic screening by 2030, and make sure that all of this is deeply embedded in our different clinics and our care models. So one of the ways that we're going to do that with Prevention for Me is to expand beyond mammography. Again, this is a very female-heavy population, so we want to go to primary care, endoscopy, urology, and just expand out that model in different settings. And then continue to do research work like these studies here to demonstrate the program impact, understand it better, bring that back into our operations, and continue to improve over time. And as I mentioned, we're trying to launch a Genome for Me 2.0 since our pilot is closing, and do that through partnerships with large-scale research-grade whole exome sequencing, and ultimately make sure that any clinically actionable content is deeply embedded in our Epic systems, the electronic health record, and automatically deliver alerts when appropriate to our providers so that we close that loop and make sure that patients are getting the care they need. So with that, I'll say thank you. This is definitely the work of many different teams across Providence, and I'm so grateful to our different teams at Providence Genomics and across the organization to enable this type of work. I know several of them are listening in on the Zoom, so I just want to say a particular thank you to them and to my colleagues across the Institute. Thank you so much for having me here. Again, it's such an honor to be able to present this work and to represent my team. And I think there's a Q&A at some point, so I'm happy to take questions for that too.
Great. Thank you so much, Kate, for a great talk. I think we have time for just a couple questions, and I think Ruth has microphone. I see Lev back there. And then for the people that are on Zoom, if you can put any questions in the chat, we'll read those out.
I can give it to you after. Thanks, that was a wonderful talk. So my question kind of deals with that criteria for population health screening having to have high penetrance. So one of the things I was wondering, so when you're selecting a at-risk or high-risk population for screening, you're going to get a lot fewer false positives and potential kind of issues with interventions. I was wondering if in your kind of broad genotyping cohort, if you've actually looked at, in the EHR, the penetrance of the conditions among the people that have screened positive, or kind of looked at other biobanks to know whether this is a good idea, just in terms of, like, for a lot of these conditions, there's pretty invasive treatments that are done as preventative therapies. And so if the penetrance is lower than in the at-risk population, then that kind of may guide the counseling.
Yeah, that's a great question. So two things there. One is, yes, that's in process. We're looking at what are the outcomes of these patients that were part of the Genome for Me cohort. We do, as part of the study, have access to their electronic health record information at Providence to be able to look at, were they diagnosed with cancer? Do they have evidence of cardiovascular disease? So that's in process. I don't have that answer for you yet, but I'm excited to find it out. And it was also a consideration for us when designing the panel that we were going to return back in the first place, because we did not just limit it to only high penetrance genes. There were also things on there that NCCN calls actionable but are more moderate penetrance. And so what we found is that that creates sort of a sticky situation, because we definitely had instances where the guidelines changed. For example, MUTYH was listed in NCCN for part of the study as having actionable guidelines for colonoscopy screening for the individual, whereas now they do not. And so in future iterations of population sequencing at Providence, we've actually kind of swung the other direction and are going to focus pretty narrowly on the high penetrance genes, just because of those situations that we experience with the moderate penetrance genes. I think there's pros and cons to that. Certainly, we wanted to make it broad enough that you could identify individuals who, almost as though they were going through a cancer genetics clinic, and not miss things. But yeah, we definitely, I think, learned our lesson in that respect, and are going to change our approach in future iterations.
Hi, that was beautiful. So I imagine that every year, like, the list of pathogenic variants will get longer. So do you have any plans to, for example, reanalyze the cohort of patients that you already did? And do you imagine to contacting the patients and telling them, hey, we didn't find any risk variant, but now we did?
Yes. So as part of Genome for Me, we do have a reanalysis process, and we have started to reanalyze some of the results, not at this point to include new genes on the panel, but to look for reclassified variants. We have had some where there has been a reclassification upgrade, so we are now in the process of recontacting those individuals who previously had a negative report and now have a positive. So I don't have the stats on that just yet, but for several of them off the top of my head, it's in the cancer and cardio part of the panel. We've also had at least one case that I can think of off the top of my head where it was a downgrade, where a likely pathogenic variant has now been reclassified to more of a risk allele variant of uncertain significance. So it goes both ways, and it creates some counseling challenges to go back to participants who may not have thought of the study in a couple of years now, to re-engage with them and make sure that they're directed to services.
I think there's one more question. This is from me, not the chat. Two quick questions. I'm sorry if I missed it. For the prevention for me, you mentioned a platform that had, I think it was patient education videos, and then GCs could also look and follow up on. Was that wasn't Epic? That was something? No,
so this is a platform that we built homegrown to try to address some of the gaps that we were seeing in sort of the solutions that were out there on the market, Epic included. Epic is great for being able to incorporate lots of data. Patients are used to using it. MyChart has a lot of the same sort of survey or family history assessment kind of questions. But where we felt that it fell a little short is that kind of education component, the user friendliness of it for patients, and being able to tailor it to something that looked and felt a little more friendly for them. So we built that from scratch and have a team of developers that we work with. That's the Propel Genomics team that's up there, to be able to build that system that communicates with Epic, but is not within Epic directly.
Okay. That's really interesting, because then for my second question, I was thinking about the finding you were talking about near the end, where there wasn't a difference between brochure and personal contact, except maybe if you started breaking it down into subgroups.
Right.
And so I was thinking about, in addition to brochure and personal contact, like, were there any other media explored or ways, service delivery models, anything else explored that might be added when you think of like different types of patients, different ages of patients?
Absolutely. And so what we did not have a chance to look at in Genome for Me, but we have interest in, is looking at, can we do some A/B testing with the actual consent itself, the website that's displayed to prospective participants. In our sample reminder communications that we also sent out to participants after they enrolled but had not yet sent back their saliva sample for Genome for Me, we did have some other outreach methods like auto phone calls, in addition to email, text, that sort of thing. We haven't looked at that yet, but I just kind of anecdotally, we found that a lot of patients didn't really respond to the auto calls because it's sort of robotic and, don't really want to pick up from a phone number, whereas an email or an SMS text seems to be a little bit easier for someone to look at quickly, scan it, and not have to pick up the phone to do that. I also think that probably the kind of provider provision of a flyer or something like that may also prove to be the most effective based on some of what we saw from the clinic engaged cohort versus the cold outreach.
Interesting. Thank you.
Well, thank you and congratulations, Kate, and thanks for everybody for being here today.
Thank you.